Welcome to Interface. Today we have an eminent scientist from University of Michigan Medical School, Professor Thomas Carey, and he was working in the field of papilloma virus infection in relation to cancer. Sir, you have been working in this area for a long time, and could you please explain what the papilloma virus is?
Yes, the human papillomavirus is a small DNA circular virus that's highly infective, and this virus has been linked to several types of human cancer, most notably cancer of the uterine cervix in women, and only in the last 15 years we've recognized that it also is a prominent and increasingly important cause of head and neck cancer.
Sir, this virus, how is it normally gets transmitted?
It's a highly infectious, very contagious virus, and it is transmitted most frequently by intimate sexual contact. So it can be transferred from one partner to another through sexual intercourse or through oral genital contact. It may also be possible that it can be auto-inoculated by someone who has an infection from one site to another. Rarely, but occasionally, we've found HPV-induced cancers of the conjunctiva of the eye. Okay. And so we guess that perhaps it could be transmitted by a finger.
Oh, okay. So, is there only a single kind of virus, or are there multiple types of this virus?
The human papillomavirus family is huge and varies tremendously. A few years ago, we had the number of discrete HPV types at something over 115. I've seen reports that there may be as many as 150 different HPV types now.
Oh, okay. How will you diagnose the presence of this virus infection?
Well, one thing that you can do to determine if somebody's been exposed to the virus is test whether or not they have antibodies circulating in their bloodstream. What we've learned, mostly from the people who are developing an HPV vaccine, is that in young women, the antibodies to the virus begins to appear about the time that women start to become sexually active. So by the age of 20 or so, most women already have antibodies against HPV.
So what kind of a disease it causes?
Well, mostly it causes a self-limiting infection, an infection that produces more virus, and the virus that's released from these lesions can go on to infect other cells, either in the same person or by passing it to a different person. Most people are aware of warts on the fingers. That is one of the many types of HPV. It's called HPV-2.
Okay.
And if you have one of those warts, the cells at the top are packed full of new viral particles. And if you have a break in your skin, then that virus can get into a break in the skin and infect other cells.
Okay. Is this the same virus which is thought of related to cancer? You are talking about the warts. It's caused by one kind of virus.
Right. So there are a huge number of what we call low-risk viruses. Those viruses, like the common wart virus or the HPV-1 virus that causes plantar warts on the sole of the foot, those almost never are associated with cancer. Then there are low-risk viruses that rarely cause cancer, but do, under occasional rare circumstances, can cause cancer. But the high-risk types are the ones that we're most interested in our laboratory. The high-risk types are closely and intimately associated with cancer and are capable of transforming a normal cell and converting it to a malignant cell. The virus is also required for the cancer cell remaining a cancer cell. If we were to use molecular techniques to knock out the virus, then that cell would stop growing.
Okay. So, what are the major kinds of virus closely related to cancer?
The high-risk HPV types are primarily HPV 16 and HPV 18 is the second most common. And then there are a family of viruses that are related to HPV 16 or to HPV 18. There are about a total of 15 now that we consider high-risk viruses and capable of oncogenic transformation.
Okay. Sir, is there natural immunity against this virus in humans?
Yes, there is. After we become infected, we begin to make antibodies against the virus, and that will prevent us from being infected by that virus again. So the majority of HPV infections might not even be noticeable. They sometimes cause lesions that are not obvious. They are productive of new virus for a period of, in women with a genital HPV infection, the estimate is for maybe 18 months to 2 years, and then it's cleared. In men, the duration of infection seems to be shorter, at least for genital infections, and that's estimated to be between 1 year and 1.5 years until it's cleared. And then people have antibodies, and they won't be infected by that virus again.
Is there any data to show that in the population, what percentage of people are protected by natural immunity?
That is a very, very tough question because the ubiquity of HPV infection is very, very high. And yet only a small number of people who become infected develop cancer. On the other hand, in India, the incidence of cervical cancer is very, very high. And it's actually, I believe I saw a statistic that said that cervical cancer is the leading cause of death from cancer in women in India. I understand that the incidence of cervical cancer is decreasing just as it is in the United States, and that's in part due to early diagnosis.
So why scientists believe that this cancer is related to HPV infection? Is it, how do you rule out that this is just a coincidence of the infecting agent in the cancer tissue?
Yeah, that's a very good question, Dr. Cannon. In fact, it's a problem we deal with when we are studying head and neck cancers. Finding the presence of the virus itself doesn't mean causation. However, we know that the HPV viral oncogenes, which are called E6 and E7, are capable of transforming cells. So after the discovery that the various high-risk types were involved in cervical cancer, people developed cell lines and then tested whether or not E6 and E7 were required for maintaining the cancer phenotype. If those are knocked down by molecular techniques, the cells stop growing. And there's an example of a famous HPV positive cell line called HeLa that caused the cancer in a woman in the United States back in the 1950s. So here we are 65 years later, and if we were to take those cells in our lab and knock down E6, they stop growing. So we're pretty certain that it is a cause of cancer. And in addition, in cervical cancer, it is extremely rare to find a cervical cancer that does not contain high-risk HPV.
Sir, another question is how these HPV infected cancers behave compared to its counterpart. Say, for example, in head and neck cancer, you can get non-infected cancers versus HPV infected cancers. Do they behave differently?
That's a very good point. And actually, no, they don't. The virally induced cancers are much easier to treat, which is good because we're seeing a tremendous increase in the number of head and neck cancers caused by HPV. But right now, we're using very aggressive therapeutic methods. For these cancers, most centers have been using a combination of high-dose radiation and chemotherapy at the same time. And while this is a very toxic therapy, we are able to cure 80% of oropharynx cancers that are caused by HPV. In contrast, if we think about using the same therapy in an oropharynx cancer that's induced by smoking and alcohol abuse, we find very, very low percentages, if any, that are cured by that regimen. The problem that my clinical colleagues face now is that the toxicity of that concurrent chemotherapy and radiation is so difficult to get through that we've had some patients who die from the effects of the therapy.
Okay.
It also has a lot of long-term after effects. So right now, we and others around the world are working very hard to try and determine which of the tumors could be successfully treated by less morbid means.
Oh, okay.
So, for example, to use surgery and low-dose radiation. And so those trials are starting now, and we hope within the next 5 or 10 years that we will be able to answer that question.
Okay. So, Professor Carey, the radiation and chemotherapy are general treatment given to the cancers. Other than that, is there any specific treatment for HPV-related cancers?
Not yet. Everybody is looking for more specific cancer treatments of all types, trying to identify what are the drivers. In the case of HPV-induced cancers, we're pretty sure that the viral oncogenes are the primary driver. If we could find a way to target those, we should be able to effectively treat the cancers. However, we don't yet have a good method of doing that.
Okay.
And so right now we're trying to use clinical information, the size of the primary, the presence of lymph node metastases, to stratify the patients who might be able to get surgery, which is specific for the tumor wherever you know it is, and radiation to try and cover what you can't see. But those are both local treatment. So if it is spread beyond that, it's difficult. And we all need to find that magic bullet for once metastasis occurs.
Yeah. So, Professor Carey, since there is no specific treatment for this particular infection-related cancers, what are the other options? Because I heard about there is vaccination available, and could you elaborate on that? Yes.
So this is one of the important breakthroughs that's happened in the last 5 to 10 years. It is possible to make very, very safe and effective vaccines against the human papillomaviruses. And it's done quite cleverly by using the viral capsid proteins. And the inventors of this vaccine just cloned the genes for the capsid proteins, expressed it in bacteria, purified the protein, and it forms into a capsid without any viral DNA.
Oh, it looks like a virus, but
it looks like a virus,
yeah.
And it induces immunity like a virus, but it's totally safe.
Oh, okay.
And it has been rated as 99.99% effective.
Oh.
So in the trials that were done early on, none of the women who were vaccinated prior to becoming infected with HPV subsequently developed an HPV infection.
Oh.
So it's a very, very promising preventive measure.
That's a good news. Sir, how this vaccine is administered? At how many doses you need to give? At what age? Could you just explain that?
Yes. So because this vaccine prevents infection, it must be given before someone has acquired the virus.
Okay.
So in studies of antibodies, it was discovered that in young women, antibodies to HPV begin to appear almost concurrent with the sexual debut.
Okay.
So in girls that are 11 or 12, it's almost never seen that they would have antibody. But as the cohorts get older, 13, 14, 15, 18, 20, the proportion of women who are positive for antibodies to HPV increases.
Okay.
And in the NHANES study that's being carried out by the CDC in the United States, it's been demonstrated that 87% of young women by the time they are 20 already have had an HPV infection.
Okay.
So it's administered to young people when they're 11 or 12 years old. And right now, the big issue is to make sure that we vaccinate everybody.
So regarding vaccination, so how many doses of vaccine is needed for a person?
That's another really good question. So in the workup to the development and preparation to make the vaccine widely available, it was observed that those people who got 3 complete doses had essentially 100% antibody coverage. So we knew that they were immune from that. However, the vaccine is expensive right now. It's newly released in the last several years. And so that has limited who gets the vaccine. So it's knowledgeable parents who have good health insurance are seeing that their children get all 3 vaccines. But some people only get one, and there are a number of reports out in the literature now that there is substantial immunity even from a single dose. So I think the companies that are developing and public health workers are trying to zero in on that, because if getting 3 complete doses and the high cost for each dose, by my understanding, it's about $400 a dose in the United States. So that's substantial, especially if insurance doesn't cover it. And also, this needs to be made available worldwide. So I think that a lot of work is being done to determine exactly what the optimal dosage should be, and find out how we can deliver it to everyone.
So as of now, the recommended regime is to 4 doses. Or you said...
No, did I say? I'm sorry. I thought it was 3 doses. Yeah. Although I'm not certain. It's not my job to develop the vaccines and do the testing, but that's my understanding. So the problem we have in the United States is that the penetrance of the vaccine into the young people is about 40% in girls are getting at least 1 dose. But I think it's only about 20% in boys. And so we need to educate parents more effectively about the risk to boys as well as girls. And we need to find a way to get this vaccine delivered in the same way we do for the typical childhood vaccines of diphtheria, mumps, and pertussis. So
is there a difference in girls and boys regarding the infection?
Yes. So the high-risk viruses that we've been talking about, HPV 16, 18, 31, 33, those are mucosal viruses. They like a moist epithelium. So the virus is more likely to produce an infection in a woman than in a man in the genital regions. So we think because of this that many women develop an infection, and the majority of them then develop immunity, and the infection is cleared. So in the people that we're seeing with oropharynx cancer, these are men in their 40s and 50s, although we also see some that are their 60s, 70s, and 80s. But the younger group is surprising, especially since head and neck cancer has traditionally been a disease of older men who have smoked heavily and used alcohol. And those tumors develop in the 60s and 70s. The mean age for our oropharynx cancer patients for head and neck cancer caused by carcinogens, smoking and alcohol, is around 65. And the mean age for the HPV-induced cancers is around 55. The other thing that we see is the patients with HPV-induced cancer is they're far less likely to be smokers. Fully 1/3 of them say they've never smoked. And many of these people are healthy and sort of the classic jogger, healthy, plays tennis, but also is clearly sexually active, that are developing these tumors. So we hope that the vaccine will influence both cervical cancer and head and neck cancer.
Head and neck cancer. So, worldwide, how is the vaccination program going on?
That's a good question. So I think in well-developed and countries that are rich, shall we say, the vaccine is being used liberally and reaches a large part of the population. So I think in Northern Europe, the vaccine program is going well. I believe that in Korea, it's also taking hold there. And so there are other places, though, where the vaccine is not being widely used, like India, for example. And it would be good if we could get a broader acceptance and use of the vaccine.
Yeah, so it looks like $400 per dose is quite high, especially considering Indian scenario. So, for an Indian scenario, what you could suggest?
Well, that's a good question. So I think there are foundations like the Bill and Melinda Gates Foundation, for example, that tend to sponsor preventive interventions. And they've done a lot in Africa for a number of diseases. And I think that in collaboration with the vaccine developers, hopefully a similar type of thing could be done in India, and perhaps with some government support and education. And if we can reduce the cost, of course, that would be helpful too. But the vaccine's new now, and so I think the drug companies are trying to recover the development costs because there's a tremendous amount of expense goes into it. So I predict that the cost will go down and that we'll be able to deliver it more evenly around the world.
Is there any ethnic difference in terms of the infection, like different people get
so we really don't think so, and I think cervix cancer is the evidence of that. Cervix cancer is pretty widespread in Northern European women. It is pretty high in sub-Saharan African women. It's high in Asia. So I think there really isn't a difference in overall susceptibility to the virus and the possibility that it will cause cancer. There were a couple of reports in the United States that oropharynx cancer in African American men was a worse disease than in Caucasian or white American men. However, that study hasn't been replicated, and I think that we need to have larger population studies. I really doubt that we'll see that there's a major difference. However, sexual mores may differ from population to population, and since having multiple partners is associated with a risk of HPV infection and development of disease, and also different sexual practices such as oral genital sex, that may increase the likelihood of an oral HPV infection and then the potential for progression to cancer. Right now, most of these cancers occur in the tonsils.
Okay. So, are there any reports that the antiviral substances or antiviral compounds like acyclovir, is it effective against this kind of infection?
That's a very good question. Acyclovir has been used in recurrent laryngeal papillomatosis. That disease is caused by HPV 6 and 11. HPV 6 and 11 also cause condylomas in the female genital tract. And so we think that when a baby is born to a mother that has an active condyloma that's releasing virus, that during birth, the baby may actually ingest some of the virus. And in the developing larynx, the immature larynx, the virus can then get to and infect the basal cell. And then once the infection takes place, then there's amplification of the virus, and the children develop warts within their larynx. And these can be life-threatening because the baby's larynx is tiny, and the wart actually fills it up. So in a young child that's hoarse frequently or has difficulty breathing should be seen to rule out the possibility of laryngeal papillomas. The other problem with this disease is that they don't tend to go away.
Okay.
In some individuals, when the child reaches puberty, the infection does go away. In others, it continues even after puberty. And so acyclovir is often used in treating laryngeal papillomatosis to try and control it. But I think that I haven't seen a good clinical study that really determines the effectiveness of it, because I think each laryngologist who treats this disease will try what they think is going to work best. So sometimes maybe they'll excise it. Sometimes they'll use a laser to burn it out.
Okay.
And then to prevent recurrence, they often add acyclovir. But I think what we need is a well-designed clinical trial to determine exactly what the most beneficial treatment method is.
Okay. So, Professor Khairy, as of now, since we don't have any specific treatment, of course, vaccine is being developed and it's being run in different countries. What all preventive measures you suggest?
Yes, so barrier methods work against HPV. And so you can reduce the risk with condom use or other barrier type methods. I've been told that dental dams are sometimes used, or a similar sort of female version of a condom. And that can decrease the likelihood of an infection. But the virus is very small, and so barrier methods are not 100% effective.
Sir, it was very informative and useful information from you, and thank you, sir, for having with us to this program. Thank you very much. Thank you.
Thank you. Namaste, sir. I'm honored to be invited to be here. Thank you so much.